for discussion, or are there questions
Oh,
that?
whoops.
Oh, they're
Yeah.
on email, aren't they?
Oh my goodness.
1 second.
One question on
Out of control.
do you guys feel like this is some a type of what was the first version of it? Do you think you guys could use this in your practice, like as far as an initial assessment of the client?
Like, is there anything that you saw that was a little bit different, but also similar? Like something you didn't put in your presentation?
The question she has is specifically in the email, do you see yourself using this in your scope of practice? Hell yeah.
I mean, it definitely sounds like you guys did a great job, and your profession as well does a great job of getting the patient's input and trying to seek out what most of these causes are, whether they be psychological or just social, whatever that may be. I think that on the whole, it sounds like something that maybe many professions struggle with and don't do enough of. It might be an area where patient satisfaction is getting knocked down because we focus on maybe more objective or healthcare things instead of asking the patient how they're doing or getting to the root of some of those other things. So yeah, I think we should.
And you bringing that up is maybe, we were kind of talking about this before, like the initial assessment process and kind of like these like techniques of talking to people and getting information from them and like giving information to them is, I'm a little bit used to that because I've worked in the field for like a few years of time now. But then to think about applying it to like the medical profession has been kind of like taking my brain and kind of like stirred it up a little bit, because I don't necessarily think about those kind of interactions like in medicine. I don't guess, kind of like what you're saying. Like social work is a client-centered approach. So when you come to me, you kind of tell me your problem and we say, okay, well, what would you like to do about it? Versus if somebody comes to a medical professional, they say, here's my problem, and they say, okay, well, here's what we'll do.
It's like the difference of who's the expert in the situation. You try to say the client's the expert on themselves.
I had a situation.
That table can go.
That table. I had a situation at one of my clinical sites, and I found out one of my patients wasn't taking medicine. So I did tell the doctor, or not the doctor, but the head nurse, that he needed to talk to a social worker, because I know, I don't know how much you guys are planning to deal with this, and if you're planning to work at a facility or a hospital, or what kind of place you want to work at, but I do know I've already witnessed calling social work. So I know you guys are prevalent. And so it's kind of cool to see different situations outside of the medical, straight
Sure.
medical. Because, I mean, I didn't realize simple things like a kid drinking could be
Yeah.
sent to social work.
Yeah.
So that's kind of interesting.
And that's another thing that OU specifically with the clinical centered practice, that's kind of the scope of the master's degree here. It's a clinical approach. It's not, a macro level thing. It's that one-on-one. And yeah, that has a super broad, of where that can be used. Ladies?
Did we pull up the questions? We have any other questions?
They had some.
Yeah.
Sammy?
Oh, yeah.
I was just gonna say that, I mean, as an SLP, we're dealing with communication, and you're very much dealing with communication, and it's kind of figuring out how to bring out what they're thinking internally, because a lot of times with us, we're dealing with these clients who they can't even, say their name right, or, something that's very easy for most people. And so kind of having that emotional or empathy to it, and kind of making them feel like you're not judging, but still not, doing it in a way that's almost subtle. And what you guys did was very subtle, where you were kind of saying, empowering, like you said, where it's client approach, which is something that we do too, even though we have the assessments and, we have the tools, whether we're, putting a nasometer up to them or an electrolarynx. I mean, we're still dealing with what they're thinking.
Sure.
So I think that aspect is very similar.
Yeah, see, in things like that, I would never think of that, from those kind of.
I had one before Tisha goes, just while we were still on this topic, but you have the situation where a patient is required, or a client in this case is required to go to you, and I've heard that kind of thing happen with PT before as well, where you have somebody who's maybe not electing to go, and how that plays out when you got to meet with somebody who's like, ugh, whether they pretend to be asleep or whatever it is when you show up. And I just wanted to say that I like the way you handled it, because it wasn't about sort of that argument of they just told me I had to be here. It was, well, what do you want to do? You turned it into, look, we're here. Tell me what I could do to help. But just from talking to other PTs, I've heard that kind of report before of, okay, people who are coming and how do you get somebody kind of invested in something?
So what does somebody get mandated to PT for?
Post-surgical.
Okay, so like
Yeah.
you've got to go post-surgery, okay.
Or workers' comp.
Okay.
Yeah.
Yeah.
So that was my thought when I was thinking about crossover sorts of things.
Yeah.
Sorry, Disha, go ahead.
So I think we are supposed to, as physicians, do patient-centered care, like you guys do client-centered care. I just think what happens is if you have a 20-minute visit with someone where you have to go through all of their systems, go over their medical history, go over their medications, if they have any chronic illnesses that actually do take a lot of time to manage, then you're kind of rushing against the clock. So ideally, we're supposed to do what you guys do and look into the psychosocial factors, look into the lifestyle factors that affect their health. And sometimes we're rushing against the clock, and sometimes I think in med school or with physicians, we get so bogged down in the science that we can lose the person. So I think that it's something that it almost has to be taken up by the individual physician, the individual person saying that, I really want to do patient-centered care versus, give you a lecture for 20 minutes. But again, like you were saying, people are mandated to you or people are mandated to PT. Sometimes people are mandated to the physician. You
Right.
have to come, you got a new job, you have to come in for a screening. And they don't want to be there. And I'm in medical school and I can't tell you the last time I went, I just really want to go to the doctor.
Sure.
No one ever said that. And
Yeah.
so,
Said no one ever.
yes, said no one ever. And so it's not something that, people are not usually happy to be there,
Yeah.
especially if it's like an acute or like emergency setting.
Sure.
And so it's kind of something that I feel like in medical education isn't valued as much or prioritized as much. And it's kind of sad because I think the people that suffer in the end are the patients. Because they
Absolutely.
walk away feeling like we don't care. And that's not the case, because none of us would go through what we go through or do what we do or study as much or spend as much time as we do away from other things if we didn't care. But it's sad that at the end of the day, like that's what gets lost in our profession sometimes.
Mhm. And correct me if I'm wrong, but like the DO differentiation is kind of your guys' is more like a holistic approach as far as like trying to take less invasive routes first. Is that like, am I totally off there?
No, that's right, and you guys can chime in too. That's right. It just again depends on the specialty, depends
Sure.
on the circumstances. But I think like we're getting pushed to see more patients,
Yeah.
and so you spend less time with each patient,
Sure.
and then they're walking away feeling less hurt. So it's kind of being between a rock and a hard place. But
Yeah.
again, like I think it's up to the individual person to kind of work within their circumstances.
Well, and the point I was gonna make is just like it seems like with that approach, like trying to take less invasive things and then move towards like more of a medical only centered approach, it seems like that you guys are probably doing a better job at like the core values of your profession to take a more client-centered approach.
Try, but again, sometimes
Push up the,
So we're
push up
taught,
HCOM.
we're taught body, mind, and spirit, like everything plays a role in who the patient is.
Yes.
And how their treatment is going to benefit them and affect their lives. And so that's one thing that makes us, we tend to be more empathetic towards anything that's going on in the patient's lives. However, we're still able to do all the specialties such as cardiovascular surgery and things like that. But when you're there, you've got a high turnover rate. You have to get in and you have to see these patients, and so you really can't take that time for each specific patient to connect with them personally and to see them as sometimes more than, okay, we have to get in and do the surgery so that you can go on and be the person you are.
Yeah.
So I mean, it's always a little bit of give and take.
I was gonna say, it sounds like from what you guys are expressing is you guys specifically don't have time. It's not that the patient won't be there long enough. So what I'm thinking is that it would be smart for us to invest our time into finding ways, you know, like to use multiple disciplines. You have a series of short questions, and if anything is ticked off, go to the social worker. You know, and then we can be more inclusive of different. So then you don't take on more responsibilities than you already have.
I think that happens a lot more like in a hospital setting than in like primary care. I think that
Okay.
it's when you're going to the doctor for your checkup, and you come in once a year, and then you're only spending 20 minutes with your doctor, and you didn't get to like explain everything that happened the last year. So I think it's primary care that faces it more than necessarily the people that work in a hospital setting.
I was just thinking in terms of time constraints, it seems like nursing also faces this, but I've always been really impressed with how quickly you're able to connect with patients while you're doing other things. And I mean, that's the thing, when I think about good nurses that have been involved in my care, they can do both at the same time. And I don't know if you're taught to do that or how you pick up that skill, but that's always really amazed me.
Yeah, we're like taught to do like therapeutic communication. So like obviously like if you're getting somebody's blood pressure, you're not just gonna be like, so what's your normal blood? Like you're not gonna be just asking about that. You're gonna
Come
be like,
here often.
yeah, like that. You're not gonna be asking that kind of thing. You're gonna be talking to them, and like I like to get to know my patients. So I know a lot of nurses, like obviously you're gonna be taking care of them mainly for the day. So like you want to get to know your patient, and like so you can. It's not gonna be awkward, and you're just sitting there like, I'm just gonna take your blood pressure now. Like it's more of a connection, and I think it makes nursing more personal.
Yeah.
Because I mean I personally really like to get to know it, but yeah, we're taught therapeutic communication, so to listen to patients if they're having a problem, talking through it with them, just like generally listening and being there for them.
But
So
it just always strikes me that it's so condensed for you. Like your patient encounters are usually pretty short, but you're still able to do it. So I don't know. Did you have something on
Part
that,
of
teacher?
what I would just add is that we teach nursing as both an art and a science. And so I think that we try to, in our profession, treat them as equal. And so the art is the getting that patient to feel comfortable, that whole piece of, like she mentioned, therapeutic communication being part of that. And so that's something that we stress from the beginning. And so we also, we get a report on our patients before we see them for the most part. So we have a brain and we have, all that critical medical information, so that we don't have to spend that time asking as much about their diagnosis. We can have more time to
That's the tricky
ask
part.
about them
Yeah.
as a person with knowing their diagnosis usually in advance.
Right. Whereas maybe in medicine, you've got to get to that diagnosis, and you've got a huge range of possibilities you got to try to narrow in on. Okay. Well, that's too bad.
We're back to this.
Yeah.
back to this.
All right, go ahead, Sammy. And then I think we are going to have to move on because we got to get everybody
Well,
else. But-
I was just gonna say, I mean, like, I know for our clinic, we try to send out, like, a checklist or some sort of, like, survey for them to fill out so we can get an idea of what is walking into the room. But a lot of times, kind of like when we try to give homework to our clients, I mean, people get caught up in their own busy schedule, and you kind of do this prioritizing. But, and I think two completely different things, but when it comes to like the blood pressure and stuff like you're talking about, I know my blood pressure fluctuates a lot. And so if I'm not comfortable or if I'm anxious, which usually is what happens when you go to an emergency room, you're not going to get anywhere near the scores that you were supposed to get. So I think that that's also like if there's no other reason to give that communication to your client, then you're not going to get your accurate science out of it.
Thank you. All right. Well, we're going to pick this up too. Again, this is going to be part of a discussion when we talk about electronic health record and how maybe it helps with this problem or maybe makes it much, much worse. So in terms of communication with patients. So it's a topic we're going to hit again, I promise. So I don't want to totally derail it, but I do want everybody to get a chance to go tonight and for Audrey to go feel better. So
Well, yes, be good. Thanks, everybody.
All right. Who's next? All right. You feeling the need to wipe this down? I'm trying to think about our universal precautions here. Are we okay? All right. Whatever you need.